So welcome and thank you for joining the Addressing Drug User Health in Every Community webinar presented by UCHAPS and NACCHO. Our speakers today include Cameron Hartofelis, Jeffrey Long, Michael Kilkenny, and Michael Brumage. Cameron is the Syringe Services Program Coordinator for the Baltimore City Health Department's Community Risk Reduction Services Unit, where she is working on the expansion of the city's syringe services program into nearby counties. Jeffrey Long serves as the Health Program Administrator for the Baltimore City Health Department's Community Risk Reduction Services. That includes the Overdose Response Staying Alive program, the Syringe Exchange program, and the Block Project. Dr. Michael Kilkenny is the Physician Director of Cabell-Huntington Health Department in Huntington, West Virginia. He's the Health Officer for Cabell County and the City of Huntington. The Cabell County Harm Reduction Program was one of its first of its kind in West Virginia. Dr. Michael Brumage is the Executive Director of Kanawha-Charleston Health Department, as well as the Health Officer for Kanawha County and Putnam County, West Virginia. He's also the co-chair for the West Virginia Adverse Children Experiences Coalition. So we'll begin today's webinar with Cameron. Your line is open. All others, please mute your line.
Hi there. We're actually going to have Jeff give a little bit of a background on our program, and then I'll finish up and talk a little bit about the expansion. So, hand it over to Jeff.
Yeah. Hello, good afternoon. So I'm actually just giving a little background on our program or whatever. The Baltimore City Syringe Exchange program actually started in 1994. And so we have about 23 years in, and we actually started out with a $50,000 3-year pilot program or whatever to actually see if syringe exchange would actually make a difference in public health in Baltimore City. So our mission statement is the Baltimore City Syringe Exchange Program is a harm reduction and prevention program for intravenous drug users. The program is an evidence-based intervention designed to reduce the spread of HIV, hepatitis C, and other bloodborne infections. These services are provided to the community without judgment and are free of charge. So pretty much, we actually operate our program using mobile units. We used to actually have a fixed site, but we haven't had that fixed site in maybe about 5 years. Mobile units actually work for us, being that we're actually working in an urban environment, because we're able to like move around, and it helps with strategic planning. So we can like.
Jeffrey, can I interrupt you for 1 second? Your line has a lot of static. If you could just adjust 1 second, and go ahead.
Okay. So I was saying that we operate off of mobile units because it helps us move more strategically, and we can actually change locations at moment's notice. So some of the services that we actually provide, of course, they include syringe and other safe injection distribution. We also do health and harm reduction education. We provide wound care. We also provide vaccines, not just to our clients, but to the general public. Anyone can actually come on our mobile units and receive vaccines. And we also do overdose prevention and response education. Our overdose response program actually was implemented in 2004. So we actually have a lot of time in on that too. And it was added as a component to the syringe exchange program. That has significantly expanded since we started. Some of the other services that we provide are HIV and syphilis testing. We also do reproductive health. We have a women's reproductive health program that we operate. We also distribute male and female condoms. And we also do ID assistance. We do referrals of treatment, and we also do linkage to care for HIV coming to our program, and one of the reasons that we attribute that to is that people are coming from outside jurisdictions. So just a little data on our clients. In FY16, we actually served 3,091 clients. 1,268 were new. We also, in 2015, we actually changed our distribution model. We went to a needs-based distribution model, which significantly increased the amount of syringes that we actually distribute. And in FY16, we actually distributed 1,225,858. And even that is increasing because in this FY, we're currently almost at 1.5 million. That is definitely up because before we went to a needs-based model, we basically were distributing approximately 550,000 syringes a year.
Hopefully you can hear me clearer now. So, I'm sorry. We actually have a small staff. We have about 5 full-time community health educators, 2 part-time community health educators, 2 part-time peer educators, and we have a management team of the program director, program manager, and assistant program manager. And as stated earlier, Cameron is now on. She's actually the program coordinator for syringe services expansion. So we actually have a small team and we do a lot. Also, since our program has been implemented, we actually started with a transmission rate, HIV transmission rate of around 64%, and today it's less than 6%. I'll hand it over to Cameron to explain what's now.
Hey, y'all. Okay, hopefully you can hear me. So just to give a little bit of context for the expansion, just last year in May of 2016, SB 97 passed in Maryland. This is actually very similar to the legislation that exists in places like New York State. What it does is it authorizes the establishment of opioid-associated disease prevention and outreach programs. So basically, it allows for syringe services programs to be developed and implemented across the state. They do have to be passed through, they do have to be approved through the local county, or the local county and city health departments, in addition to the state program. So there is this kind of application process that we're going through. But otherwise, we're expecting to see programs popping up all across the state. Now, what's happening with the Baltimore City program is because we were, for a long time, the only needle exchange in the state, we've been providing a lot of technical assistance for the state as programs get started. And I just want to give you a better idea of what that looks like. So right now, we are working with the Anne Arundel County Department of Health. There was a lot of interest in kind of counties surrounding Baltimore City for us to actually come in and provide support and to expand our services as a way, partially, of getting our services on the ground fast. Because, we're a program that's been around, like Jeff said, for over 20 years. So what does that look like? In actuality, really it's a lot of meetings and a lot of research. So what we'll be doing this summer is we're doing client surveys. As Jeff said, we've got something like almost a quarter, if not a little more. We're thinking it's probably higher to a third of our clients that come in Baltimore City to our programs are actually folks from outside, from Baltimore County to Anne Arundel County. So what we're doing is trying to reach those folks, get information about where they think we should be expanding services, where they see, overdoses happening, where the hot spots are, so we can get client feedback and as we move forward. And then a lot of the work also is looking at epi data for the county, figuring out trends, who we really need to be reaching. We know that in Anne Arundel County, we're going to be seeing a much younger population. We'll be seeing more young Caucasian men, which is not necessarily the who we're serving here in Baltimore City, though we are seeing more folks coming in from the county, like we said. So a lot of it is just kind of figuring out what exists already. Anne Arundel County, we can talk about this more, has a great Safe Stations program that just was piloted. So that's a fantastic thing for us to look into. And then a lot of it is just talking to folks doing programming that might not be specifically needle exchange labeled, but kind of is harm reduction labeled. And so what will be happening in the coming months will be a lot of targeted community outreach. I'm hoping to do focus groups with drug users, neighborhood associations, get in meetings with local law enforcement, talk to local politicians, care providers, CBOs, and then the really fun part of program planning and program implementation. So we're hoping to get things on the ground later in the summer or the fall. That's about it for us. We're happy to answer any questions you might have. But yeah, we'll maybe hand it back over to Ivory, and we're happy to answer questions about our program, about the expansion and how that's going, and look forward to hearing more about the rest of y'all's work. Thanks so much, Ivory.
Okay, great, thank you. No problem. I'll hand it over to Dr. Brumage in Kilkenny. Just give me 1 second.
Am I good?
Yes, your lines are open. Go ahead.
Yeah, this is Michael Kilkenny in Huntington, West Virginia, and I'll first of all ask how my audio quality is because I'm on speakerphone, and is there very much static?
No, you sound clear.
Okay, if things sound clear, then that's great. If you can give me our first slide, we'll start talking. I'll start out and I'll kick it over to Dr. Brumage at any time. But I want to start by just going over the kinds of issues that we're dealing with in West Virginia. On this first slide, you can see our hepatitis B rates. West Virginia in 2014 led the nation. Cabell County was much higher than the average state rate, and I think that Kanawha County was very close to Cabell County in the hepatitis B rate. We keep track of the 2016 rate also, which is has not been reported out publicly yet, but is holding steady for at least for Cabell County. Our 2017 looks like it's rising. We do have the advantage in the local health department of having regional state epidemiologists who can keep us appraised of just exactly what's going on almost on a day-by-day basis. On the next slide, let's look at our hepatitis C problem. West Virginia was #1 in hepatitis B, #2 in hepatitis C, but 2016 could change that also. It's not a title that we really are seeking, but we may achieve it. The rates in Cabell County were slightly higher than the West Virginia rates in 2014, but we took a big jump in 2016. I put a big asterisk there because there was a change in case definition for reporting, and I wanted to make sure that I marked this slide so that when it reappears 2 or 3 years from now and we forget why we had such a big jump, it was partly because of a change in case definition. It's also because there's been an increase in hepatitis C in our area. Overdose death is a huge problem here. Again, we have the United States. From 2015, at the far left, the state of West Virginia led the nation in 2015. Cabell County was much higher, and in the city of Huntington, overdose death was the 3rd leading cause of death in 2015. That rate only got worse in 2016. Non-fatal overdoses we track on a monthly basis. And as you can see from this slide, we had a huge increase in overdoses, non-fatal overdoses in the last 4 months of last year. We were able to map the takeover of fentanyl from heroin about that same time, and the arrival of carfentanil in Cabell County was in August of 2016. And we saw a rapid increase in fatal and non-fatal overdoses in the months following that. The next slide shows the neonatal abstinence rates. This is an older slide back to 2013 when Cabell County noticed that we had about 10 times the national rate of neonatal abstinence. And if there's any trend in the slides that we saw before, it was that we had 10 times the rate of hepatitis B, we have 10 times the rate of hepatitis C, we have 10 times the rate of overdose death, 10 times the rate of neonatal abstinence syndrome, and you do not get that from 1 times the number of injection drug users. We have 10 times that number also. The history of harm reduction in West Virginia does not go back to 1994. I think we had heard of heroin at that time. I'm not sure that we were aware that there was such a thing as syringe exchange in those days. But by 2014, we had figured out that we had a significant problem and that we needed to do something about it. Prior to 2015, all syringe exchanges in West Virginia were kind of under the radar type of access programs, but in 2015, the legislature passed a Good Samaritan law allowing opioid antagonist access, and with that came a kind of acceptance of the problem and the need for official action to solve our problems related to injection drug use. That opened the door for Cabell-Huntington to start a harm reduction program in 2015. Kanawha-Charleston started later that year. Then in 2016, we got pharmacist-directed dispensing of naloxone, which really helped community naloxone distribution. And at current time, we have about 7 counties that are operating syringe access programs. If it would be all right now, I'll turn it over to Mike to talk a little bit.
Thanks, Mike. This is Mike Brumage, Mike Kilkenny's colleague. Just as a little bit of background for people who are attending this webinar, we're both communities of around 50,000 people in West Virginia, Huntington a little bit less. We're right at 50,000 in Charleston. Kanawha County, West Virginia has 197,000 people. And in the metropolitan area that is around both Charleston and Huntington along the I-64 corridor, there are about 360,000 people representing about a fifth of the state's population. In contrast, that's just a little over half of what Baltimore's city's population is, and certainly not the Baltimore metropolitan area. We were very fortunate in that the Cabell-Huntington Health Department, under the leadership of Dr. Kilkenny, had started their syringe service program in September 2015, which allowed us to rapidly jumpstart on their coattails in December 2015, and have been going strong ever since and growing at really an alarming rate. So halfway through 2017, this is through our harm reduction clinic that we had on June the 21st, we had a total of 6,182 patient visits with 1,747 new unique patients during that time period. We have 727 people who have received other services such as HIV, Hep B, C, screening, immunizations, long-acting reversible contraception, and a thing that we see quite a bit of here, which is taking care of wound care. We've distributed through 2017 to date about 167,000 syringes and received 102,000 back. And we're really fortunate in that we have partnered very well with one another. And so we have linkages to care for hepatitis, HIV. We have a Ryan White program in Charleston that we can refer patients to, although we've only had one that's tested positive, and we're fortunate in that regard. As Mike Kilkenny has already alluded to, our hepatitis B and C rates are just astronomical. We're also lucky to have community naloxone access programs. Based on the recommendation from Dr. Kilkenny, we requested Evzio auto-injectors from Kaleo Pharma, and have distributed over 700 of those to date. And we have at least 160 known saves from that program. I know that Dr. Kilkenny over in Huntington has much greater numbers of number of people saved. One of the things that we are fortunate to be able to do is to, we do a modified 1-for-1 because we have limited amount of resources to buy syringes. We just, in the last couple of days, had a visit from researchers from Hopkins who came over from Baltimore and talked to us about going to a more open, needs-based syringe distribution program, which we would gladly do based on the evidence we've heard from them, but it's just a matter of getting enough resources to do that kind of thing. One of the other things I want to make sure that I touch on just briefly is the perception in our community when they see syringes in the community environment, in public places, parks, and so forth, is they attribute sometimes those syringes to the syringe service program. And I think my standing line is we have syringes in public places because we have a heroin problem, not because we have a syringe service program. And so we have a little bit more work to do. But in that regard, we're also purchased through a grant funding a receptacle for needles that we'll have so that people can turn in needles when they find them in a safe way. And we've also recently leased a device called a Sterilis device. Sterilis is a device that has a 4-gallon drum in it, and you can put regulated medical waste, to include syringes and needles, into that drum. It basically autoclaves it at 140 degrees Celsius. So it's a superheated steam, runs for about an hour, and then it grinds the remnants into confetti that can be then put into the regular waste stream and not into a regulated medical waste. So we hope to demonstrate to the community that we are serious in terms of helping remove syringes from the surrounding environment. So with that, why don't you go ahead and go to the next slide, Ivory? And Mike, you want to take it from here about your partners and how you started in Huntington?
The point of this slide is not necessarily who we partner with, but that we partner with everybody. Dr. Brumage has a great many partners in the Charleston area, and Huntington has a great many partners with our program. But we actually partner together to try to provide services all along the I-64 corridor. And we will partner with anybody at any level. I have met Mike Botticelli. Mike Brumage has actually met Barack Obama in regard to harm reduction, and we will meet with anybody from a church group to the President of the United States to try to provide services for these people who are suffering from their disease. Let's move to the next slide. What we've recognized and Mike alluded to, is that we have very limited resources to provide these services. Although we have a terrific epidemic of opioid use, substance use disorder, and all of the complications that go along with that, we've seen an unprecedented reduction in state support to local health, and local health seems to be carrying the torch on expanding these programs. So we are doing our very best to gather money anywhere we can. What we find, though, as each new program starts up, there are limited wells to go to draw water. We could go to the next slide. And so by teaming together, we can, instead of compete with each other for philanthropic dollars and other funding, we can form coalitions and are in the process of forming a West Virginia harm reduction coalition that can compete for dollars on a global stage and then divide them up amongst the partners. The West Virginia Harm Reduction Coalition is actually Dr. Brumage's brainchild, and I will kick it back to him to discuss the coalitions just for a minute.
Well, thanks, Mike. And I think that's a really important lesson for everybody, either with an existing harm reduction program or thinking of starting one up, is how do you join your resources in order to become more effective, and you get some economies of scale when you can do that. We started with actually just meeting for breakfast along with law enforcement and some academics to discuss what we could do to address the opioid epidemic in our region. And it grew into an action group that's began what we call the Great Rivers Harm Reduction Coalition. Dr. Kilkenny applied for and received funding through a couple of different agencies, and we since have been able to hire an executive director for that regional harm reduction coalition, and now is the cornerstone for the beginning of a statewide harm reduction coalition. The idea, just like in Baltimore, as they provided expertise to other harm reduction clinics who are thinking of getting started, that's the purpose of us, is to kind of put our heads together to be able to show best practices and to compete as a unit for funding rather than against one another. Mike?
Yeah, if we go to the next slide, we'll just run over real quickly what some of our demographics and performance data are. These are Kanawha-Charleston demographics here, similar to what was presented from Baltimore, but with a bit more female than Baltimore had. In Huntington, we actually have about a 55-45 split, 55% male. So a remarkable increase in the percentage of female. The next slide shows the race distribution. In West Virginia, the entire population of West Virginia probably is 5% African American. In Huntington, it's about 8%. Mike, it might be about that in Charleston also, isn't it?
Yeah, yes, that's correct. We have a large African American population on the Charleston's west side, but the predominance of our patients are white.
Yeah, we are actually only seeing about 2% African Americans in our harm reduction program, and we're doing some outreach into the African American community to determine whether that's their need or whether they're being underserved and how we can serve them better. The next slide shows the growth of the Kanawha-Charleston program in the numbers of visits that occurred. The Cabell-Huntington program grew faster at the beginning and then leveled off rather than more the kind of straight line growth that Kanawha-Charleston had. But within a year of operation, Kanawha-Charleston had surpassed us in numbers. We did see about 1,980 new patients in 2016. And it just is amazing that when we hear Baltimore presenting 1,200 new patients, and we had 1,900, and Mike, you had 1,700. Is that not right?
That's exactly right.
So we're talking about a huge syringe exchange and harm reduction program for really a small community. And we think that in some other parts of this country that would be classified rural like we are, although we're in cities, we still consider ourselves rural. We think that this is a problem in those cities. The next slide shows some improvement in actual performance as to why we do this. This is a Cabell-Huntington statistic. The new clients that came to us in 2016 reported sharing needles at a 16% rate or 15.7. Those people had no access to syringe exchange or harm reduction prior to being new clients here. Our return clients, however, are sharing only a 4% rate. So although we've shown no decrease in hepatitis C yet, we've certainly shown a decrease in the behavior that correlates, and it's only a matter of time before the disease rate follows that performance. So that's all the slides that we have.
Hey, Mike, can I throw in another comment here about the hepatitis C?
Sure.
Yeah, so one of the concerns I have, and what we get asked frequently, or I do at least, is how is this program affecting your hepatitis rates? And so I think in the short term, what we're going to see is, because we're testing more, is that we're actually going to see the hepatitis C rates go up. Now, many of those will be undiagnosed prevalent cases as opposed to new incident cases. But that's something to keep in mind. As you begin to test more, of course, you're going to uncover more. So it may lead to the false perception that because now you have a syringe service program that the hepatitis C rates are going up, that therefore you're not effective. And so something to bear in mind as you begin to test more and more frequently. And that's all. Thanks.
Okay, we have a few questions for you. We have one from Laura Cooper. She asks, what are some of the best practices, programs, media campaigns to implement to lessen potential stigma that may surround syringe exchange programs in rural areas? Anyone's free to answer.
Mike, do you have an answer about the stigma question?
Well, I wish I had an answer about the stigma question. I just attended a seminar this morning in West Virginia that was involving an EMS component and a neonatal abstinence component, and had some people there from early childhood development and other things. And there was tremendous stigma still associated amongst those providers in that group. So I think that overcoming stigma is something that we've not gone very far on, and I know that Mike Brumage shares compassion as I do with these folks. Besides developing programs and implementing them, we also work in them and talk to our clients, and these are great people. These are just wonderful, good, loving people that deserve our care. So I'm hoping that that time will help us in the stigma issue.
Yeah, I like to say that IV drug users are the modern day lepers that nobody wants to see, touch, or have anything to do with. And it's very difficult to change that, especially among healthcare providers. And I think Mike probably has a similar experience, but we hear every week how many of our patients who visit our syringe service programs feel abused and degraded by their experiences in the regular medical system. And when they come into our clinics, actually, they are the most grateful of all patients that I've ever had, of any group of patients I've ever worked with. So it's rewarding work once you get to do it, and it really will help dissolve some of the barriers. And my hope is actually to bring more and more people into our clinics, because we have to rely on volunteers. We can't just do it ourselves. And many of the volunteers come in with some jaded views and leave with an entirely different perspective. So I think exposing people to that, if that's possible. But as we talk about taking care of the people using, we also have to be aware of the suffering that both families and friends are incurring because of this, but especially our first responder communities. They are being burned out. I know that in Charleston, it's routine that between 8 and 12 overdose calls per shift for some of these folks, and this is it's really taxing them. So that's another issue around stigma that I wanted to answer. Ivory, are we going to be looking at some of the questions that are coming from the chat boxes? Because I see there's one here from Andrew Torgerson, who was asking us, was there much political legislative resistance to syringe exchange in Huntington or in West Virginia, and how do you deal with that problem? I'll let Mike discuss this one a little bit more, but to say that West Virginia as a state does not have any laws prohibiting syringe exchange programs. And so all of the work that was done here was local in terms of getting ordinances changed, for example, for syringe possession. And that's what enabled us really to get started. But we don't have a law one way or another, so we kind of work in that regard. Mike, do you want to add some more?
Yeah, we were not prohibited from doing syringe exchange except in our own minds. By the time I took my job, which was really just 2 years ago, my first day on the job, they were telling me that we were thinking about a syringe exchange, and I was saying, what's that? But I've learned really quickly. And just early on, when I was meeting with the public, every family in Huntington is affected by this disease, and they were really clamoring for me to start a syringe exchange and do something. That's not to say that it's been really easy. We've recently reached out to another agency to partner with us and provide services in their clinic, and they politely told us that they were very happy that we were doing it in ours, but sorry.
Okay, we have another question. For Baltimore and West Virginia, what sources of funding have you been able to leverage?
Maybe Baltimore should take this one before we talk about West Virginia.
I really wish that Baltimore would take that and tell me where they got the money for 1.5 million syringes in a year, because I want tap onto that too.
Well, hearing nobody from Baltimore on the line, I certainly hope they'll chime in anytime and talk over top of me to interrupt me. What I can say is here in Charleston is that we started with donated supplies. And we had a few people who actually wrote checks to us to help us get started. So it was the donated supplies and it was the volunteer work of really dedicated people in our community who helped get us up and running. So we were kind of building the plane while we were flying it, financially speaking. But since then, we have applied for every way of funding humanly possible to include a number of grants. And some of those grants have started to trickle in now and have helped us finance what we're doing. So it's a combination of donated supplies, grants, and certainly the manpower is all, well, at least predominantly volunteer. Mike?
Yeah, we've been able to get some funding from philanthropy. We were able to get a pilot grant from the state for about $10,000, but since then we've been able to leverage other grants a little bit more effectively.
Hello.
Jeffrey, your line is open.
Yeah, so this is Jeff from Baltimore. To answer your question about the funds, so we actually receive about $865,000 annually from city general funds, and then we get about another $290,000 from the state of Maryland to actually do syringe exchange. But we also get some additional funding also from the state of Maryland for overdose response programming.
Yeah, in our first year of operation, I was able to pull in about $110,000 to support the startup, and I don't think Mike Brumage even got that much.
No, we got $10,000 from the Kanawha County Commission. That was the only official government taxpayer funds that we received was $10,000.
Okay, we have one more question from Alyssa. Your line is open.
Henry, do you want to just read the question?
Sure. In terms of funding, have you thought about redirecting CDC or other federal funds since you've received a determination of need?
So once we did go that route, we went through the HHS website, we wrote to CDC, we demonstrated to their satisfaction that we had a need here, and that was supposed to be our ticket to get funding through both the CDC and HHS. And as we made those requests up the chain, what we found out was that they weren't really looking for counties to do this. They were hoping that states would be the drivers of that. So we had this sort of strange situation in our state where many counties were asking for this kind of funding, but it was intended to come through the state. So we have, although we have a certificate from CDC, a letter, we do not have we have not received funding so far through CDC directly. So we're still looking. However, we do have a very good working relationship with CDC. And I know Dee Bixler, who used to be in Charleston in the state of West Virginia, is now at the Centers for Disease Control and Prevention and has been a willing partner to help us out in any way we can. So we're looking forward to developing those relationships a bit further.
The state of West Virginia did redirect some federal funds into the community naloxone distribution program. We were able to get about 800 two-dose units of naloxone to distribute in our organization. We had gotten about 2,500 two-dose units from the manufacturers prior to that. So we've not had as good luck getting either federal or state tax dollar support.
I think Alyssa had another question here in terms of working with state viral hepatitis prevention coordinators and getting buy-in from law enforcement. I don't know if you want to take either one of those, Jeff or Mike.
Well, I can't say enough about our law enforcement. Our police chief has been on board with this since before we had the exchange. He's known for a long time that law enforcement cannot arrest this epidemic to its end. And we get a lot of support. We've even had police officers patrolling the syringe exchange to protect it from any disruption so that those citizens could receive services.
Mike, have you had much interaction with the state viral hepatitis prevention coordinator?
Yeah, there's some stuff going on at the state along those lines, and I've been on different panels and planning groups with them. I know there's a good bit of action on hepatitis in the state from the Bureau.
We can talk a little bit about law enforcement if folks are interested. And I'm fairly new, but we do have a fairly long-standing relationship with the Baltimore Police Department. I mean, that's been something that we've been around for so long that I think folks started to see, even if they were skeptical at first, that this was something that was really having an impact in terms of really helping connect folks to services, helping to get folks clean, and not having those detrimental effects. You know, that this wasn't just going to be like free-for-all syringe everywhere mayhem, that it was actually really helping them do their jobs to be able to have the syringe program helping out folks who were using, right? And something that that maybe Jeff can talk a little bit more about that has been piloted, and this is something that I think was first piloted in Seattle fairly recently, was the law enforcement assisted diversion, or LEAD program. And basically what that does is instead of like having a drug court where you go to court, you completely skip the court part. So you can get arrested for a minor drug infraction. That can be possession. I think, I don't know the exact specifications, but I do know that it can be like a minor paraphernalia or possession, nothing like, you know, large scale intent to sell or things like that. You completely skip the kind of court part of drug court and basically can get directed straight into treatment programs. And that's been piloted in Baltimore City, like in a smaller area in a neighborhood in Baltimore City, and we're hoping to see that expanded. And also in Anne Arundel County, I might have mentioned this, there's a Safe Stations program where, independently of having a harm reduction program specifically, they have something that just launched in April where folks can go to any firehouse, any fire station in Anne Arundel County, show up, have paraphernalia on them, have drugs on them, not get arrested, and be treated by EMS and get referred straight into services with no criminal charges made. So we're seeing, at least in our, regionally, that law enforcement are sort of starting to come around. And of course, there's been lots of meetings, lots of trainings, but I think that they're really seeing, as these programs get implemented, how much of a difference they're making and how much safer they can make our streets. So.
Okay. Are there any more questions for our presenters today?
All lines are open if you have another question to ask. Okay. If there are no other questions, I just wanted to thank our presenters for sharing your work with us. And before you all log off, please take 30 seconds to complete the 2-question survey about today's webinar. The link to the survey is in the chat box, so feel free to click on the link and take just 30 seconds to complete 2 questions. And if you have any questions for us, feel free to reach out to UCHAPS or NACCHO at the phone numbers on the screen, or email us at info@uchaps.org or info@nacho.org. And thank you guys. Have a good day. Bye.
Thanks so much, y'all. Bye.
I think it's done.